Let me just fix my camera. Good evening, everyone, and welcome to the webinar. I'm Claire, I'm the editor of Medical Chronicle, and I'm joined by Sister Phoebe Bruver for her presentation of Doing Better Under Pressure, Addressing the Underlying Cause of Venous Ulcers. This webinar has been made possible by SAT. A bit of background about Sister Bruver. She is a registered nurse and advanced wound care practitioner and the owner of the wound clinic at Life Rose Acres Hospital in Johannesburg. She holds 2 master's degrees and is currently enrolled as a PhD candidate at the University of the Free State. She is the current president of the Wound Healing Association of Southern Africa and involved in developing an accreditation system for wound care practitioners in South Africa. She has extensive post-basic wound care training and research experience and is currently involved in several research projects as well as product development. Sister Bruver is regarded as a key opinion leader in wound management and is passionate about standardization and wound management education. She has several publications in peer-reviewed journals, such as Advances in Skin and Wound Care and Wounds International. So what a great presenter for us to have tonight. Here is some background about, some guidance on the webinar. If you have a bad connection, there is a box at the top of your screen that says reconnect. Please click this button. If you have any sound or image issues, it'll bring you right back into the webinar. There will be a recording of the webinar available to watch, and you can still earn CPD points from the recording. The CPD points are allocated based on your viewing time, so please do watch the full presentation, at least 40 minutes. As per HPCSA guidelines, we no longer issue CPD certificates directly, but pass on this data to the HPCSA, where you can view your points on their portal. Please type any questions that you have in the Q&A only box provided. So that's the box next to the box that says chat. There's a Q&A only box. So if you have any questions for Sister Bruver that we'll get to afterwards, please type them in that box. I need to point out that there will be no addressing of any off-label use of products. And as per CPD requirements, no brand names are to be mentioned. Please, active ingredients only. Just before I hand over to Sister Bruver, if you consent to being added to SAT's attendance register for tonight, please type the letter Y for yes in the chat box. This is not for CPD allocation at all. It's just for our sponsor's own attendance register. Okay, I will now hand over to Sister Bruver.
Good evening, everybody. Claire, thank you so much for that introduction. Thank you, SAT, for this wonderful opportunity. I hope you find this insightful and afterwards have something to take back to practice. I am very passionate about lower leg ulcers. Most of my practice is consumes treating lower leg ulcers. So it's one of my passions and I love it. So the talk is doing better under pressure because we are going to discuss compression bandaging and the how and what and when. So without further ado, let's go and start with the lecture. So our objectives for this lecture is to identify steps to success in treating venous leg ulcers. The 3 steps I will be discussing is addressing or assessing the patient, dressing the wound, and using compression. So assessing the patient will entail the holistic assessment, a vascular assessment, interpreting those results, making a differential diagnosis, and then deciding on what dressing to use with regards to your wound bed preparation and antimicrobial stewardship principles. And of course, then compression, the what, why, and how of treating the underlying cause. So in South Africa, unfortunately, we do not have prevalence data on lower leg ulcers, but globally, the problem affects around about 2% of people, and that increases to about 3 to 5% for patients over the age of 65. And when we look at the different types of wounds, about 70% of the lower leg ulcers are venous of origin, about 10% is arterial. Of those, about 15% can have a mixed etiology. And then we have atypical ulcers, which we don't see that often, but they can also come around our table. So the little steps I want to discuss, the 3 steps, is to assess and then dress and then compress. It's easy to remember, and like a lot of the international guidelines, I do like some acronyms and some easy to remember things that you can jot down and you can remember. So when we look at assessing the patient, we need to do an accurate and comprehensive assessment of the patient and the wound. That will help us determine the underlying etiology, identify comorbidities that might influence healing, and establish the healability. There's several publications now on how to heal wounds and how to treat wounds that you do not know what the cause is, and it's difficult to determine the etiology, but it's important to do a full and holistic assessment. As part of my PhD thesis, I am developing a care pathway, and the pathway has now extended into not only a care pathway, but also an assessment tool as well as a guideline. So the next slide I'm going to show you is a little bit of my thesis. I have developed an acronym to join the international guys with all the acronyms in order to do a holistic assessment. Sometimes it's easy to jot down a few letters and to remember a word, so that to help you remember the things that you need to look for when assessing your patient. So the acronym is holistic, where the H is for your health system review. With lower leg ulcers, we need to look at all the systems, from your mental health, your cardiac, respiratory, your gastrointestinal, your endocrine, autoimmune diseases, anything that might influence the healing or contribute to the underlying cause of the wound. Then we also need to look at the onset of the problem. If a wound is present for more than 3 months or has not responded to standard of care within a 3-month period, it is vital to send the patient for further assessment and maybe a tissue biopsy. Listening to your patient. We need to attend to the patient-centered concerns, pain, mobility, financial constraints, and in a country like South Africa, we need to consider the patient's general health and general well-being, social and psychosocial support systems, and access to care. Is the patient able to come to a clinic? Does the patient have funds? Those are all things we need to consider. Then identifying risk looks at the patient's age, family history, and other things that might influence the risk of this patient in either having a hard to heal or even a maintenance wound. Social would also include smoking and alcohol abuse. Treatment, we look at previous and current treatment, and that can give you an idea of what the patient has had before and what current treatment is being used to guide you on deciding what the treatment could be or might be. Information about allergies, so that you can decide what type of dressing to use, what type of compression to use, as well as other medication that the patient might be allergic to, and then your chronic medication or other over-the-counter medication that might influence healing or might contribute to extended healing period. So, when assessing your patient, you definitely, and it is indicated in all the guidelines and all the new developments on lower leg ulcers, is that you have to do a proper vascular assessment. I know in some of the far off regions that this might not be possible, and I know we have limited resources with regards to vascular surgeons, but we still, as clinicians, we can still do a proper vascular assessment by palpation of the foot pulses, listening to the sounds when you use an 8 megahertz Doppler, doing an ankle brachial pressure index, and then also doing toe pressures. So when you've done an ankle brachial pressure index, it's important to know what you are looking at. So international guidelines dictate that a value of more than 1.3 could indicate calcifications, and it is best to refer that patient for a vascular assessment. In limited resource circumstances, it might be also then good to do a toe pressure. A toe pressure should be more than 30 millimeters of mercury pressure, and in a diabetic patient, it should be more than 50. If the reading is between 1 and 1.3, that would indicate a normal arterial flow. The ABPI gives you an idea of the ratio between the systolic pressure in the ankle and the systolic pressure in the brachial artery, so that you can determine to what extent there is a peripheral arterial component in this patient. In a reading of 0.81 to 1, there's mild or not significant peripheral occlusion, and from experience, most patients fall in this category when they present with a venous lower leg ulcer. But it is advisable to just check whether the patient has a normal toe pressure as well, especially if the patient is diabetic. With a reading 0.6 to 0.61 to 0.8, there might be mild to moderate impairment in the arterial flow. And if there is any accompanying symptoms of peripheral arterial disease, this patient must be referred to a vascular surgeon. Any reading below 0.6 is an indication of severe peripheral arterial disease. And if this patient then presents with signs of critical limb ischemia, it is imperative that they be referred immediately to a vascular surgeon. So the ankle brachial pressure index guides us and gives us direction. The next thing we are looking at to determine the wound etiology is the wound duration and location, the wound bed characteristics, the wound edges especially, any associated symptoms. Sometimes we miss little things like fatigue or weight loss or weight gain, things that might indicate that there's a much bigger problem at hand. Your leg assessment, where we look at hair growth, any discolorations on the skin, edema, or your skin temperature. And then, of course, we also look at the surrounding skin. So I have another, okay, before we get to the next acronym, when making a differential diagnosis and looking at location, the wound bed, associated signs and symptoms, your leg assessment, and skin temperature, venous and arterial ulcers have distinct characteristics that will guide you in making a differential diagnosis. Venous ulcers are usually located on the medial or lateral malleolus or around the gaiter area, where arterial wounds are mostly distal, towards the foot, on the dorsum, over the tendon area, on the tips of the toes, or an area of even over an area of pressure. Mixed arterial ulcers is usually somewhere below the calf muscle, mostly in the anterior position of the leg, but can be anywhere depending on the most dominant trait of the ulcer, whether it's more to venous or more to the arterial side. The wound bed of a venous ulcer is usually sloughy or covered with granulation tissue and is very wet. And I'm sure you've seen those. Arterial ulcers tend to be pale, dry, and necrotic, where mixed ulcers can be a combination of these. Associated symptoms that we can associate with venous ulcers is your lipodermatosclerosis and severe edema. With your smaller patients or skinnier patients, the edema is sometimes not that significant, but that's one of the things of venous ulcers that make your life quite difficult, and as well as the patient's life. With arterial ulcers, you often have either intermittent claudication or rest pain. With rest pain, it is imperative that the patient gets to a medical facility as soon as possible. That can be limb-threatening. And then with mixed ulcers, it depends on the ABPI and whether there are any peripheral arterial symptoms present. When assessing the leg, with venous ulcers, there tends to be hemosiderin staining, as well as varicose eczema, dry, flaky skin. And with the arterial ulcer, the skin tends to be shiny and hairless. Once again, with a mixed ulcer, it depends on the dominant trait, whether it's more arterial or more venous. And then lastly, your skin temperature. With a venous ulcer, it can be normal or elevated, whereas with the arterial ulcer, the limb is often cold because there's no circulation going there. So now that you can differentiate between arterial or venous or even a mixed ulcer, there's a little trick that I've learned to distinguish between arterial or venous ulcer. Once again, an acronym that you can remember. So VESSEL stands for the various positions that help alleviate the pain, the explanation of the pain, which alludes more to the characteristic of the pain, the skin color, the temperature, and the nails. The next S is for the strength of the pulse, and the E is for edema. Now, it depends whether you are in the UK or the USA, how you spell edema. So, and then finally, what the lesion looks like, the ulcer's location and appearance. Now, we've touched on that a little bit. So let me just explain that one. So with your V, the various positions that would alleviate pain. With arterial wounds, a dependent position often alleviates the pain. Then with a venous ulcer, the elevation reduces edema, which can reduce pain. With those patients, initially, they usually complain of pain when they elevate their legs, but it could be the fluid shift that happens. So don't confuse that with arterial pain. That's why we look at the whole patient and not only the hole in the patient. With E, explaining the pain, arterial wounds tend to have a sharp pain or rest pain or intermittent claudication, whereas venous ulcers tend to give the patient a heavy feeling with a dull throbbing or a burning sensation in their legs. The next S is looking at the skin. With the arterial ulcer, the skin is cool to the touch. It's pale, dry, hairless, with thick toenails. Venous ulcers, you have your hemosiderin staining, a flaky skin, eczema, and lipodermatosclerosis. The pulses, the strength of the pulse, usually with an arterial ulcer, the pulse is very faint or absent. And with a venous ulcer, it can be normal, except if there's a lot of edema, it can be obscured. And with the arterial ulcer, the edema is not common, where with the venous ulcer, the edema usually progresses and gets worse later in the day. So we've touched on this, the ulcer appearance and where they are located, the tips of the toes and the top of the feet and the lateral ankle region. That's more your arterial ulcers with a deep punched out look, pile, very little drainage, and noticeable margin that gives a round punched out look. Where with the venous ulcers, you have this large, draining, wet, sometimes granulation or sloughy wound with irregular edges that's usually shallow. So I hope you can remember vessel next time you see a patient. But now, rose by any other name. A wound is just a wound? No, not usually. Although the prevalence might be low, or prevalence and incidence might be low, we do see atypical wounds, which does not necessarily fit into that picture. So these wounds require another hour lecture, but just to name a few, like your malignancies, and that's where your onset comes in. If the patient has had the wound for more than 3 months, biopsy is indicated to exclude malignancies. We also get to see quite a bit of pyoderma gangrenosum, vasculitis or vasculopathies, martural ulcers that is associated with uncontrolled hypertension, necrobiasis lipoidica, which is, although a very low incidence in diabetes, it is there. Calciphylaxis, which is associated with end-stage renal disease, even necrotizing fasciitis, and sometimes Buruli ulcers or leishmanosis, which is related to travel, which we haven't been doing that much in COVID. But as far as I know, we don't see Buruli ulcer so much in South Africa. It's more towards Central Africa, where it's more prevalent. But yes, those wounds are a reality, and you have to exclude quite a few things when you do a differential diagnosis. When we look at assessing the wound to decide on a dressing, I follow the wound bed paradigm of Dr. Gary Sibbald, in which we use debrided infection moisture in edge. So debriding, specifically for your lower leg ulcers, entails the removal of necrotic tissue. It is imperative to move the wound into the next phase of healing, and you need to determine whether there's any peripheral arterial disease before deciding on a method. So for lower leg ulcers, sharp or surgical debridement is contraindicated if the arterial supply is not sufficient. For your highly exuding wounds, hydrocolloids and film dressings are not advised. They make the wound too wet. And with wounds, you want to have a balance between not too wet, not too dry, and you need to look at the moisture level. So debriding, there's several methods of debridement, and you need to choose what is best for the patient. Is the wound healable, and what would be the best and shortest way to a clean wound bed? Infection has been the buzzword in the last few years because we are dealing with a lot of difficult and hard to heal wounds with high levels of infection. And we are looking at infection a little differently because our resources have become quite depleted. So when we treat infection, we have to consider antimicrobial stewardship principles, diagnosing the level of infection, and treating infection correctly. What is antimicrobial stewardship? Well, that aims to reduce the inappropriate antibiotic use, to reduce antibiotic resistance. So we have limited resources, and the International Wound Infection Institute has worked very hard having the right patient, having the right antibiotic for the right patient at the right time with the right dose and for the right duration. So we focus on the correct diagnosis, appropriate treatment, and we evaluate the efficacy as we go along. Once again, looking at the International Wound Infection Institute document, they have plotted the infection continuum, and we look at a wound from either contamination right through to systemic infection, and we look at biofilms and to decide what type of treatment it would be the best for this patient, looking at where there's an increased microbial load, the virulence and the numbers of the bacteria, and what to treat and when to treat them. So for biofilm, I know some people tend to think biofilm you can just see on a wound. Unfortunately not. We have to look at the clinical indicators thereof to decide whether a wound has a biofilm or not. And even then, it's not a given. But we look at recurrence, we look at delayed healing, chronic inflammation, friable granulation, and then your COVID signs of infection. So in local infection, we can look at either covert signs of infection or overt signs of infection. Your overt signs of infection is your usual classic signs of infection: erythema, heat, edema, your purulent discharge, pain, malodor, and then delayed healing. But your COVID or more subtle signs are the ones that we tend to miss: your friable granulation, delayed healing, epithelial bridging and pocketing within the granulation tissue. There might be areas of wound breakdown. The patient might complain of a new pain, and there's probably malodor. So if there's a recurrence, delayed healing, chronic inflammation, and most of these COVID signs, you might consider the presence of a biofilm. Biofilms are difficult to treat, but they're not impossible to treat, but they make our lives quite difficult. And then, of course, spreading infection. So if it spreads into the deeper tissues, we have erythema, cellulitis, wound breakdown. The patient might even be getting sick, having malaise and loss of appetite, and an increased CRP level. So when we treat infection, we still need to utilize the wound bed preparation. We look at debriding necrotic tissue, which can be the source of infection. We treat the infection according to the level of infection, and managing moisture often helps us to treat the infection. And usually, I say it's almost like baking a cake, but I won't give myself out as a baker at all. But this is one of those foolproof recipes that if you debride and remove the source of the infection, you treat the infection properly, the moisture often becomes less of a problem. Optimizing the host response. We're looking at the whole patient and not the hole in the patient. So you're looking at oxygenation. Is there oxygen going to that wound? And the patient's nutrition, which is very important. In that sense, we employ the services of a good dietitian to help us decide what would be better for this patient. And then, of course, your antimicrobial stewardship principles, which indicates the appropriate antimicrobial and doing a wound bed swab only when there's deep infection or spreading infection, appropriate antibiotic treatment according to the wound bed swab, and then evaluating the efficacy of both the antimicrobial and the antibiotic every 2 weeks. So when you decide on a dressing, a Cochrane review done in 2018 actually indicated that there's no specific dressing that is superior, but your dressing choices must consider the wound bed prep paradigm. Do you need to debride? Do you need to treat infection or moisture? According to the wound characteristics. So an ideal dressing should be able to prevent adherence of the bandage to the ulcer base, allow drainage, yet maintain a moist environment, and prevent infection with bacteriostatic properties. When we look at the venous system, I'm sure you know how the venous system works. Standing, the venous pressure can be between 80 to 100 millimeters of mercury pressure. And when we walk, the venous pressure is reduced to 10 to 20 millimeters of mercury pressure in the calf and foot muscle pumps. So walking, we usually advise our patients to walk a lot and elevate a lot so that we prevent retrograde blood flow and prevent venous hypertension and edema. So when I saw this meme, I thought, if I was a compression bandage and you go for a job interview, I wonder if this is what they would ask you. Because when I thought about the title, initially I thought I wanted to play Queen's video under pressure, but we couldn't do that. So, but I'm not going to sing the Bohemian Rhapsody. That will take too long. So in our last step between assess and dress and compress is, of course, then compression therapy. So compression therapy is the gold standard in treating venous ulcers. There's various types available, and it can be used in ulcers with mixed etiology when modified. Please take note, this must be done under the supervision of an interdisciplinary team. In elastic compression, there is some proof that it can significantly improve impaired venous hemodynamics without impeding the arterial flow in mixed ulcers. We advise, and most of the guidelines advise, do not use compression on arterial ulcers, or if the ABPI could not be measured, and do not use in persons with non-palpable or monophasic foot ulcers. But why compression? So compression has three major benefits, where it can reduce edema, it reduces the capillary filtration, it shifts fluid into the non-compressed regions, and it can improve lymphatic drainage. The effect on the veins, it actually results in venous narrowing to reduce venous pooling and improve the venous pump action by reducing the diameter of the major veins. It can also, especially inelastic or modified compression, increase the arterial flow. So the three types of compression that is available currently is your inelastic, elastic, and multi-layer compression systems, where your inelastic system gives you a high working pressure and a low resting pressure. And with your stiffness index, or your dynamic stiffness index, the high working pressure is what we look at and what is important to improve the venous flow and reduce backflow. With your elastic bandages, you have a high working pressure as well as a high resting pressure. So that sometimes is uncomfortable for patients if there's a continuous pressure. But for patients with a lot of edema, the elastic bandages can help to reduce the edema quickly. And that's where your multi-layer comes in, where it's a combination between an inelastic and an elastic bandage, with also quite a dynamic stiffness index and a high continuous pressure. So the principles of compression. Compression is based on Laplace's law, which indicates that the sub-bandage pressure is directly proportional to the bandage tension, but inversely proportional to the radius or curvature of. In essence, it is important to remember that you cannot use too narrow bandage, you cannot apply too many layers, and you need to know how to apply the bandage. Remember that a smaller circumference can give you a higher pressure. And within most of the bandage ranges, there is a guidance on measuring the ankle circumference, which is something that you need to do before applying a compression bandage. Because incorrect bandaging can lead to skin damage, necrosis, reduced arterial flow, and edema in the wrong places. What does the evidence say? Compression increases ulcer healing rates compared to no compression. Also, a Cochrane review. Multi-component systems are more effective than single-component systems, and high compression is better than low compression. But some compression is also better than no compression. So, it is important to consider the clinician's skill. If you do not know how to apply a compression bandage, make sure that you acquire that knowledge and skill. The experience. With some of the studies they've done, they've measured different levels of experience, and there is a difference in experience in the way people apply compression bandaging. And then, of course, the compression system quality. Some are equal, but some are more equal, if you remember that book. Then treating patients with lower leg ulcers is definitely a team effort. You need to identify key team members with appropriate skill and training. You need to collaborate with team members on the best possible treatment options for those patients and communicate with the team members. It is vital for the patient's health and benefit that we communicate. Finally, considering the patient's quality of life, a lower leg ulcer, especially a venous ulcer, can impede on a patient's quality of life by influencing activities of daily living and just their basic quality of life. I'm talking about odor, a leaking wound, pain, things that prevent them from continuing with their life. So they often withdraw from social events because of a chronic wound. And that's sad, because we can treat them, we can help them. Just a few practice skills to remember. Applying the knowledge to your practice. Remember a holistic assessment to identify the underlying cause. A vascular assessment to exclude the PID. Wound bed preparation, applying your antimicrobial stewardship principles. The correct compression for the correct patient at the correct time. A skilled healthcare professional to apply this compression, and teamwork. Thank you so much for your time. I hope it was insightful. And even if you know everything, my one motto is that you can always learn something new. So I hope that you did. Thank you very much.
Thank you so much, Sister Gruber. That was excellent presentation. I have to say your slides were beautiful. I appreciated them, and I appreciated the reference to Queen's Bohemian Rhapsody. But besides that, your message is very important. So thank you so much for sharing with us tonight. We've had a few interesting questions, and I'm going to ask them try and ask them in the order in which they appeared. Okay, first interesting one is, how important is an increase in protein intake in the diet for a patient with a chronic venous ulcer?
Very important. If we look at underlying causes of venous ulcers and contributing factors, one of the things that we usually look at is albumin levels. And it's important that you consider the patient's general health. So yes, considering kidney disease as well, looking at the patient's health and general well-being and nutrition is very important. They need that in order for that wound to heal. You can do a lot of things and put a lot of fancy dressings and compression, everything on there, but if the patient doesn't have the necessary resources, it would make life difficult for you and the patient.
Okay, so nutrition, especially protein, is very important in wound healing. Someone has asked, sharp or surgical, if arterial sufficient versus insufficient?
So if there's arterial insufficiency, that needs to be addressed first. If you are not sure about the arterial supply, do not attempt any sharp debridement. Stay away from autolytic debridement as well. Make sure that you have established whether there is arterial supply. That is first and foremost. And if there's none, you refer the patient immediately.
Okay, great. Okay, bear with me. This is quite a long question.
Okay.
Is there an electromagnetic capillary pump based on the membrane water molecules distribution, creating a piezoelectric effect? Do we still believe that venous return is solely based on the difference in pressure between the arterial side and the venous central pressure? What is the role of earth in promoting the difference of potential between the water molecules close to the endothelium and the water molecules in the center of the capillary vessel? And then is asked again, is there a capillary pump? Now, I'm not sure what that earth is referring to in what is the role of earth in promoting. I don't know if that's a typo, but maybe you understand that. I don't really.
A good question, but I don't have a clue.
Okay. Okay. We're in the same boat.
There's a lot of studies where they look at your white cell cuffing and a few things. What initially causes venous hypertension, but on a molecular level, I'm not sure whether we are there yet. At this stage, I'm thinking, if especially if you look at our resources, it would be wonderful if we have all sorts of interesting molecular devices that can pick up whether there's a problem between the venous and the arterial system and where the problem is. I don't know if one of the vascular surgeons have an answer for this, but I'm sorry, no, I don't know.
Okay, no problem. What group of analgesics do you recommend for venous ulcers?
To be honest, your pure analgesics are still the better ones. If a paracetamol, purely because of trying to move away from things that might influence the patient's kidney function, or influence anything else that might not be good. So a paracetamol, but usually with your venous ulcers, once you have the edema under control, the pain becomes less of a problem. A good debridement with good pain control and proper compression alleviates that problem in essence. So then you won't need so much pain medication in any case. But paracetamol still your safest and best analgesic.
Okay, great. Thank you. Any statements, advice about negative pressure applications, please?
Okay, negative pressure definitely has a place. In our environment, it is imperative that you still treat the underlying cause. I have published a paper on the use of negative pressure in conjunction with a 3-layer compression system, and you do get a much better effect if you can manage the edema and manage the wound exudate, especially with your large circumferential wounds, where it's difficult to manage the exudate. But you must also remember to manage the underlying cause. You cannot move away from that. Now, unfortunately, in South Africa, I know our medical aids do not authorize the 2 different modalities, which is a problem because you can either treat with negative pressure or compression, and that sometimes is a bit of a conundrum. But I think negative pressure definitely has a place in treating lower leg ulcers, but it shouldn't be your first choice, not necessarily. It depends on the wound location, depends on the patient's pain level, exudate. There's quite a few things that might influence your choice of dressing there.
Okay. Can untreated but asymptomatic varicose veins lead to venous ulcers later in life?
No, not necessarily. It depends on whether, actually, one of the vascular surgeons in Cape Town had a talk the other day, and although not everybody with varicose veins will develop a venous ulcer, but it does increase your risk. So it doesn't,
Okay.
it just it increases your risk, but it doesn't guarantee you will have an ulcer. No.
Okay. Someone commented, excellent presentation. I guess best to refer all or most leg/foot ulcers to a wound clinic. Would you agree with that?
Yes, in a sense that these wounds are usually chronic of nature, and they take quite a while to heal. You need a proper assessment, but you need a team effort. So everybody needs to be on board in the type of treatment that you're going to use, and it's not only one person that will treat this wound, but the whole team. Everybody needs to be involved. But if it's a wound clinic with good experience, good clinical knowledge, and the right tools to assess the patient and treat the patient, definitely, yes.
Okay. How often do dressings need to be changed? That's quite a practical question.
Okay. With compression bandaging, the rule of thumb is usually that we do a follow-up within 24 hours after the first application. Purely because of the large fluid shift that happens. When the edema reduces, the bandages often move down and they do not work like they should. Also, so that you can assess how the patient reacted within the first 24 hours to the treatment. Then another bandage or dressing is applied. It also gives you an idea of the level of exudate you are dealing with. Then after that, it depends on the level of exudate, and it depends on whether there's infection. Most of the research guide us that you shouldn't be applying compression when there is full-blown infection. So that depends on that as well. If there's infection, you will obviously see the patient more often until the infection is resolved. Then you can start with compression, and then the same applies. You follow up the patient within 24 hours. Once the edema is reduced and the wound has stabilized a bit more, then the patients can be followed up on a weekly basis. It just depends on the size of the wound, the exudate, and how the patient reacts to the treatment.
Thank you. The previous question, one of the previous questions, George just elaborated that he means earth as in the electrical circuits, but yeah, so I didn't know what that was referring to, but this isn't my field, but I think still what you said applies, is that we wish we had this molecular information, but we don't always. Is there any role for hyperbaric oxygen treatment?
In chronic wounds, there is quite a debate about hyperbaric oxygen treatment. I would think all the advanced modalities definitely has a place, although there's limited evidence to support the use. That does not mean that it doesn't work. If you look at the basic wound healing physiology, the wound needs oxygen to heal. If you can, by means of either hyperbaric oxygen, or then the new trend seems to be topical oxygen application, increase the oxygen level and increase healing times and rates, of course, yes, it does have a place. Within the South African context, I also just think it's one of those things that we have limited resources to, and because there's little understanding of where it fits into the treatment paradigm, that's why people think it might not be a good modality to use. But if you look at the mechanism of action behind it, surely it has a place if we have access to it, and if the patient can be exposed to something like that, or have access to that resource. Yes.
Okay. Another question about dressing types. Please, could you expand a little? For example, bacteriostatic silver nitrate included, etc.
Okay. If you look at your dressing hierarchy, for instance, where we use dressing classifications, you get dressings that donate into the wound, and you get dressings that I know I'm at a loss of words. Let me just think. You get dressings that bind to wound properties, for instance, bacterial binding dressings. So once again, it depends on what resources is available to you. When we classify wounds, we tend to want to move away from things, or classify dressing, sorry. We want to move, and looking at antimicrobial stewardship, we want to move away from things that donate into the wound, and rather start off with something that has, like, let's say, bacterial binding properties, so that you do not donate into the wound. But it depends on your level of infection, for instance. It depends on the level of exudate, and depends on what is available to the patient and the resources. So it's not that there's one specific dressing that works for everything. It depends on the patient and the situation. Okay. I hope that answers the question.
That's great. George, you asked the question before about the water molecules, has just expanded, and it's more of a statement, but I'd just like to read it out because I think it's interesting. He says, it is a known phenomena that water molecules close to a membrane create a different structure as opposed to those far from a membrane. Thus, the difference in potential creating a linear electromagnetic motor. I agree. Few are familiar with this concept, but it ought to be considered. The pressure effect might be thus explained. So thank you for that, George. That's very interesting. Someone has asked about choice of antibiotic on empirical usage. What is your choice?
Also, I mean, we don't prescribe. We work in a team. Our clinic works as a team. We have surgeons, physicians, physios, dietitians, and the wound clinic, and also orthotist and a podiatrist. They're all part of our team. So we all work together, and it depends on the bacterial swab. It depends on your MCNS that you've done with your wound swab. Empirical antibiotics, I know there's a lot of controversy about that as well, but if you look at antimicrobial stewardship, we try to move away from just empirically starting an antibiotic, but rather doing a swab, waiting for the results, and then starting the antibiotic. I know in some cases it is difficult to not treat the patient immediately, but then once again, if you look at your broad spectrum antibiotics, starting on an antibiotic, one of your just broad spectrum ones without naming anyone, is still considered safe. But then if you do a swab, you need to indicate to the pathologist that the patient has started on antibiotics, so they can also have an idea of what to look for. So it's, once again, the whole patient and not the whole in the patient.
Good point. And you also bring up the important point of having a multidisciplinary team working with the patient. Trish Idenson commented, take a look at the International Wound Infection Institute updated 2022 edition, and she left the link. So thank you very much for that, Trish. Please advise on getting a recording. Okay, the recording of the presentation will be sent out an hour after the presentation ends to everyone who registered. Any use of sclerotherapy for varicose veins in the presence of venous ulcers. Sorry, tongue twisters tonight.
Yes, there is some good data on using sclerotherapy. Once again, if you are properly trained in that and you work together with an interdisciplinary team, there is some good research to show that there is some benefit in sclerotherapy. Also, one of those things that 10 papers say it's good, and then that one paper says it might not be good, and it was a small group of people. So it's also depends on the patient, depends on the resources. But yes, there's a place for many of the adjunctive therapies that are available. It's in our environment, it's just not available to everybody. But there is definitely a place for most of the adjunctives out there.
Okay, thank you so much. The questions seem to be slowing down. If there's anything more, please let me know. Otherwise, okay, wait. Steroids with comorbidities must be considered. What's your take on that?
Steroids with comorbidities. Well, some of the wounds, like let's say pyoderma, the patient is treated with steroids, with corticosteroids. And yes, once again, the patient, it must be a comprehensive assessment where you consider how the corticosteroid might influence the patient's glycemic control. But with patients with underlying comorbidities that require corticosteroids, you need to consider that when you're treating the patient. You need to be proactive in preventing infection, debriding the wound properly, managing edema. So yes, I hope I understood your question correctly. But yes, that is something that you need to consider when treating comorbidities, is what medication the patient is on and how it will influence the wound healing.
Okay, great. Thank you so much for your time tonight and sharing your knowledge. It's been very well received. Loads of positive comments in the chat section. So thank you so much. And Thank you to SAT for making this possible. And really, thank you for the good work that you do. I really take my hat off to all wound care therapists, because it's not easy, but it's so meaningful for the patients that you treat. So really, thank you so much. I just wanted to point out that we have a pediatric HIV webinar next week, Tuesday evening. So please do join for that. It'll be presented by Dr. Leon Levine, so a really knowledgeable expert in his field. So look out for the email with the registration link for that. Okay, thank you so much to our audience also there's the link in the Q&A only box to register for the HIV webinar. Thank you, Anel. Thank you for our audience, as always, for being so participative. I think that's a word. And for all your questions. So yes, we look forward to hosting you for 3 webinars next week, but look out for the one on Tuesday night, please. Excellent presenter, excellent presentation. Thank you, Sister Phoebe Bruver. There we go. So, I mean, that says it all. So thank you so much, and have a wonderful week, everyone.
Thank you. Bye-bye, everyone.
Take care. Bye.